welcome everybody. This is a joint event hosted by the Rural Drug Addiction Research Center and the Minority Health Disparities Initiative at the University of Nebraska-Lincoln. I'm Trey Andrews. I co-direct the Minority Health Disparities Initiative, and we're excited to have Crystal Badour, Dr. Badour here for this joint event. She'll be giving the talk on using a health equity framework to understand trauma and substance use in rural Appalachia. So as a brief bit of background and maybe some disclosure, I've known Dr. Badour for quite a while. We were just talking. It's been 15 years now that we've known each other. Been quite a while. We trained together, worked together, and I've just been always impressed with the quality of work that Dr. Badour does, even since our earliest days in graduate school. These days, she's a licensed clinical psychologist and associate professor in the Department of Psychology at the University of Kentucky. She's also the co-founder and co-director of the University of Kentucky Clinic for Emotional Health, CEH. Her research focuses on understanding factors involved in development, maintenance, and treatment of psychopathology following exposure to violence and other traumatic events. So again, welcome, Dr. Badour, and excited to have you speak with us. I'll go ahead and turn it over to you now.
Thank you so much, Trey. Trey had to disclose how long we've known each other, and I wasn't really ready for that. But I'm excited to talk with you all today about some of the work that we've been doing. I have to apologize because I do have a cold, so I'll try to keep it together for this. I've been trying to save my voice. I am going to talk about the health equity framework that we are thinking about to understand trauma and substance use in rural Appalachia. And I'm going to mostly talk about Appalachia today and our work in that area, although some of it will overlap. And I will say that much of Kentucky, most of Kentucky is rural, but only part of it is in Appalachia. And there are some unique features to Appalachia that I will try to highlight as we get going. So I want to start with a few disclosures just to say that I'm going to talk about a wide variety of studies today. And I could not do this work without a ton of collaborators and a ton of support. So each of the funding pieces here are going to be involved in some of the studies I'll discuss. So I'm going to start today by just talking about a few key definitions and providing a bit of a framework for how we're thinking about work in this area. And then I'm going to talk a little bit about what we know about treatment of PTSD and substance use disorders and the work that I have been doing in this area for a long time, really before I started moving into thinking about health disparities and health equity. I'll talk a bit about substance use and trauma in Kentucky specifically, and then also thinking about what we understand about Appalachia. And then I am hoping to have time today to talk to you a little bit about our work in the area of sleep and its intersection with substance use and trauma as well. So in terms of key definitions, I think it's really important that we're on the same page, especially with things like trauma, because this isn't always defined the same across people who might be speaking in this domain. So when I'm referring to trauma here, I'm talking about as defined in the DSM-5 and the PTSD criteria, criterion A. We think about trauma as any type of event that involved actual or threatened death, serious injury or threat of serious injury, or sexual violence. And when we're thinking about health disparities, we're really going to be talking about particular health differences across populations that are linked to social, economic, or other environmental disadvantage. And health equity is, in somewhat the flip side, what we're really striving for to help reduce health disparities and achieve health equity. And so there we're really thinking about a state in which everybody has a fair and just opportunity to actually attain their highest level of health. And a lot of this work really does rely on thinking about social determinants of health. So these are those non-medical factors that influence a variety of health outcomes. And so in the case of the work that I'm doing, we are really thinking a lot about economic deprivation, rurality and lack of access to services. And then also there are some unique features related to discrimination and other pieces that people experience in Appalachia as well. So I love this diagram to start off the conversation of a framework, and then I'll have a more formal one in a moment. But I like to think about this, and I imagine many of you have probably seen this or a similar image. And here I'd like to walk through thinking about this with a giving tree. I have a 5-year-old, so I love the giving tree. A shout out to any parents who've spent a lot of time with this book. But the top left diagram is where we think about inequality, the idea that there is unequal access to opportunities and resources, right? So the person on the left has access to the apples. The person on the right is left wondering, where am I going to get the apples? And for a long time, we as a society have really talked a lot about equality and thinking about ensuring that we move to a space where everyone gets the same tools and assistance so that they can achieve good health outcomes. But what I think increasingly our field and other fields are recognizing that we can't give everyone the same tools, because the system, if you think about the tree as the system, is still set up in a way to advantage some groups over others. And so moving into a framework of equity is where we start to think about how can we customize tools that really identify and address these inequalities, and identify unique adjustments that we can have to support certain groups and individuals. And then ultimately, our goal really is to move more towards a justice framework where we are actually fixing the systems that are perpetuating these health disparities. And so I'm going to present the NIMHD framework, health framework here, which guides a lot of our work. And it didn't for a long time for my work. So I actually was trained as an experimental psychopathologist and very focused on individual factors. So I think one thing that many psychologists are guilty of is really focusing so much on the individual level. And we will often focus on different domains of influence. If you think about like biological and behavioral, sociocultural, et cetera. But we are often not thinking about the person in their context in the same way that I think other disciplines that study health have done a better job of. And so this is the framework really that I'm going to be thinking about as I talk through my shift into thinking about health disparities and health equity. So I mentioned I started off as an experimental psychopathologist, but on internship and postdoc, I really wanted to move into thinking about clinical trials and thinking about how to evaluate treatment efficacy and how to modify treatments to make them more effective. And I was actually really trained in the trauma space and PTSD space first, and came to substance use later as I started studying the intersection of these two things and thinking about the unique facets of treatment. So very briefly, I'm gonna just highlight some work that I was really fortunate to be involved in on internship and postdoc, which is a treatment referred to as COPE, concurrent treatment of substance use disorders and PTSD using prolonged exposure. It's really, I think, the longest name for a treatment I've ever seen, but COPE for short. And so I was fortunate to be involved in the efficacy trial, establishing the first bit of controlled evidence in veterans that COPE can lead to greater reductions in PTSD symptoms compared to relapse prevention, which is sort of a standard cognitive behavioral therapy for substance use disorders, and that the outcomes for substance use are actually similar. So this was great to see, as historically people with this co-occurring set of disorders were often not receiving trauma-focused treatment because of concerns that might exacerbate symptoms. So this was great. And I continued for several years to do a lot of work in this area. And some of the findings that we found were that, as I said, PTSD symptoms improve more with COPE, robust effects for people who are completers. The majority, the overwhelming majority, lose their PTSD diagnosis. We also found, as I mentioned, that substance use improved similarly in both treatments. About half of the patients in either treatment obtained at least 3 weeks of consecutive abstinence during the course of the treatment. And we also found that trauma processing did not exacerbate symptoms. And that was really important at the time. And now it's something that's, I think, starting to finally translate into standards of care. So I mentioned that shortly because I think what I really want to focus on and how I've started to shift a lot of my thinking and the work in our lab is really thinking about the challenges that come out of these randomized clinical trials. So I'll use COPE as just an example of this. So one of the things that we started to find was that while the treatment is great for people who can access it and can complete the treatment, dropout is actually quite high. So only half of participants in this controlled trial completed all 12 sessions. And then we know that people in community-based settings are typically going to receive even less than they are in these trials. We also found that things like higher substance craving and distress after engaging in exposure did actually increase a likelihood of dropping out. So we need to be thinking about kind of titrating this treatment, how we can make it more accessible and more attainable for other people. There are also some important differences by race that started to be found. I will say, though, this trial was not really designed to look at racial differences in outcomes, but some of the things that were found in Black veterans compared to white veterans were that Black veterans tended to be older, they had more severe PTSD as well as more severe drug and alcohol use, so sort of presenting to treatment with more severe symptoms. They tended to see actually greater improvement in drug and alcohol use during treatment, but also a greater worsening as during that follow-up period of 6 to 12 months, suggesting if this is something that can be reliably found, perhaps we don't even just need to be thinking about racial and ethnic differences in responses to treatment, but also thinking about things like follow-up and booster sessions. And then we did see for Black veterans, their greatest decreases in alcohol consumption occurred in COPE, whereas for white veterans, we actually saw the opposite. So that I think is one important area. And then the last thing I'll say about, thinking about moving clinical trials and efficacy trials out into the community is that there are real implementation limits to a lot of our existing therapies. So COPE, as an example, requires 90-minute individual sessions that are delivered by a highly trained trauma-focused provider. And for those of you who might work with in community settings, you probably know that this really is difficult, if not impossible, in a lot of settings to implement. So we did actually find some evidence that perhaps this treatment could still be effective if the exposures are shorter. So thinking about, maybe moving down to an hour-long sessions and 90-minute sessions. And this is old news now, but at the time we were really excited pre-COVID that we demonstrated the use of COPE effectively and safely for delivery via telehealth, because this was also something that people were really concerned about. And we thought it might have a lot of implications for delivery, particularly to rural patients. So I think the sort of takeaways of a lot of the work that I had done in terms of putting it in this social ecological model or this framework of the individual embedded in their context is it's not only individual level factors that might make a treatment like COPE really difficult for people to benefit from. So if we start at the individual level, there are a lot of things that we often think about in treatment outcome research that might be relevant. So yes, treatments can be distressing, especially trauma-focused treatments. There's been a lot of interest in understanding that. Things like low motivation or ambivalence to change, obviously very relevant in both of these conditions. Physiological dependence and may actually alter the course of treatment outcomes for people. Negative treatment attitudes, internalized stigma. I don't deserve to get better, right? Things like that. But also individual experiences that people have in terms of housing, food insecurity, transportation barriers, other things of that nature. But when we step outside of the individual, we see things like peer groups who use substances can make this extra complicated. If someone has an unsupportive or perhaps abusive partner, if someone has experienced past negative interactions with therapists or other care providers. And then if people also have other related stressors that involve interactions with people at work, people in caregiving, and that can make it really difficult. When we move to the level of community, it gets even harder, right? We've already talked about some of these things here, and that there's really a lack of providers, particularly when you get into rural areas, but really there's a lack of these specialty providers at all. We also find that provider attitudes and training within a community of particular clinics or particular areas can be a barrier. There are still a lot of attitudes that and beliefs around, can we do trauma-focused training, or trauma-focused therapy in substance use disorder clinics, that type of thing. Things like facility resources and priorities. Again, if we're thinking about the community level, at the level of care facilities, hospitals. Things like lack of access to childcare or transportation at the community level can be really important. And I think about public transportation here as a really important one to think about. And then there are also community attitudes and discrimination against people who use substances. And one of the things that we've really found, particularly in rural areas, is oftentimes there's one clinic that might be serving substance use care, that might be serving mental health care. And people don't want their neighbors to see their car in the parking lot because that might lead to them wondering, what are you doing there? Is there something wrong with that person? And there are a lot of negative stereotypes about people, particularly who use substances. And then at the societal level, we really have to think about, I'm going to talk a little bit about our work with justice-involved women today. And so we have to think about social policies and laws that really are quite punitive and really interfere with recovery from both experiences of violence and other traumatic events, but also from substance use. We see a whole host of societal inequalities based on race, gender, sexual orientation, social class, urbanicity. So in Appalachia in particular, and I think this is true in other rural areas as well, people experience a lot of discrimination based on their accent and ideas and beliefs that because they are from Appalachia and they have an Appalachian Eastern Kentucky accent here, that means that they're not as smart or they're uneducated. And then, of course, we also see discrimination against people who use substances and just healthcare structure overall that makes it very difficult to access and benefit from care. So a myriad of challenges. So with that framework, I want to talk about some of the work that we started doing in Kentucky. And this has been a really big shift for me. Like I said, I wasn't trained as a health equity researcher, health disparities researcher. But through my work in the co-occurrence of PTSD and substance use, I just couldn't ignore the fact that the people who often needed services the most were the least likely to be able to access them. And that was not an accident. And so I started shifting in this way as I came to Kentucky. And started doing more and more substance use PTSD overlap research for a variety of reasons. But I show this map in part to show that in Kentucky, like in many places, we have a substantial problem with drug overdose deaths from opioids primarily, although not entirely. And so Kentucky has one of the highest rates of overdose death in the country related to opioids. And if we were to look at this broken up by the state, so I'm in Lexington. There's basically really two urban centers in the state of Kentucky, Louisville and Lexington. And outside of that, it's predominantly rural. And if you look at the western side of the state, it's more flat, more agriculturally oriented. And when you look on the eastern side of the state, it's super mountainous, very beautiful in the Appalachian Mountains. And historically has been economic opportunity has really been driven by coal mining and other sorts of logging and other manufacturing related activities. And a lot of those resources have really dried up. And so we see a lot of unique things going on and some unique challenges in Appalachia in particular. So these data, just to show you a little bit about some of the challenges about substance use in Kentucky and its overlap with trauma, why we should think about and care about this. This isn't specific to the rural parts of Kentucky. This is actually data from all across the state. These are data, the Kentucky Treatment Outcomes Study, or KTOS, are data collected as part of a routine outcomes monitoring system in Kentucky. It's really great that we have this. So there's an intake that's provided to everyone entering outpatient or inpatient substance use treatment facilities in the state of Kentucky. And a random sample of about 20% are invited to complete a follow-up a year later, which has led to some really robust information, as you might imagine. When I got to Kentucky in 2015, I met with the director of the PI of this study, and I said, what about violence? Can we include questions about violence and PTSD in this? So this was the first time actually it had been assessed. And so these data that we have, a sample of about 9,000 participants, we were assessing violence and PTSD in substance use treatment outcome facilities. So it's about half and half in terms of women and men, predominantly white sample, which is commensurate with what we see in Kentucky. It's an overwhelmingly white state. So in terms of the problems that we're seeing with thinking about violence and substance use is that, in fact, particularly in substance use treatment seeking sample here, we see dramatically high rates of violence. So we found that 3 out of 4 people who were seeking treatment had been a victim of violence. 4 out of 5 of those, 4 out of 5 cisgender women, and more than 4 out of 5 trans individuals identified that they had experienced violence. Although it's important to note the number of trans participants were very small in this study. And we found that 23% of people who had experienced violence were screening positive for a current diagnosis of PTSD. So that compares to about somewhere around 1 to 3% in the general population who experiences current PTSD. So this is quite elevated. And the majority of people who have PTSD are cisgender women in this sample. Okay, so let's talk a little bit about some of those social determinants of health. What we find about patients with PTSD compared to patients without who are seeking substance use care is that they're more likely to have been poor, to have difficulty paying rent or utilities, to have been evicted, to not have enough to eat. They've either avoided either medical care or medications due to cost in the past year. They're also much more likely to have been unemployed prior to entering in treatment, more likely to have experienced homelessness. Interestingly, actually, in our state, people are more likely to live in urban areas if they have PTSD, although nearly 75% of the sample reside in either rural or very rural areas. We also find that patients with PTSD come into treatment with more severe alcohol and drug use problems, and that's really consistent with what we've seen in prior literature. Interestingly here, patients are no more likely to be part of a minoritized racial or ethnic group, but those comparisons are really difficult given the overwhelmingly white nature of the sample. So I didn't have space to fit my wonderful graduate students on the last slide. So Christopher Penn is a graduate student working with me, and he has led up a lot of this work. And then Jesse McCann is also taking up some of this as well. So we've been trying to look at what is the impact of violence and PTSD on substance use treatment outcomes. So one of the things that we have found, which we did not expect, is that at the 1-year follow-up, patients with violence histories as well as with PTSD actually see no difference in their trajectory of substance use treatment outcomes compared to people without PTSD. So that's great to hear, is maybe suggesting that people with PTSD are benefiting as much as people without. However, these are very messy data. So this is sort of a crude way of looking at this, and we're hoping to refine this more in the future. Despite the fact that folks with PTSD are benefiting as much from treatment, perhaps, we are finding that patients with PTSD are actually reporting lower satisfaction with their treatment. And that's even after accounting for the improvements that they're seeing in both alcohol and drug use and in quality of life. And one of our hypotheses is that perhaps, we're not sure about this because we don't actually have the data to speak to it, but perhaps these folks have other mental health issues that are not being addressed adequately in their care in substance use treatment settings, that we're hoping to follow up and try to understand this better. So the data I presented so far is thinking about, all right, well, let's think about how things are going in standard care and what are some of the challenges that people with trauma and violence experience, and how is that overlapping with social determinants of health. Well, we're also going a little bit different direction, and we're thinking about kind of going back to what I mentioned about COPE, in that it's a great treatment, works well, if you can get it, if you can finish it. And so we're trying to think about, well, might there be an alternative treatment that would make it easier for patients to finish it and to access it? And so one treatment that we're really excited about is written exposure therapy. And I'll first talk about that, and then I'll talk about written exposure therapy integrated, wet eye. So written exposure therapy is a relatively new treatment, although it's been being studied now for several years, but it is a relatively new treatment for PTSD that has shown non-inferiority to sort of our two best standard treatments. So prolonged exposure therapy, a trial just came out related to that, and cognitive processing therapy. So the great thing about that is that both prolonged exposure and cognitive processing therapy are very intensive treatments. They involve 12 sessions, at prolonged exposure, typically 90 minutes, and they involve needing to have specialized providers who can provide the care. There's a lot of homework involved as well. And what we see in patients, particularly who are also taking treatment for substance use, is that there's often a lot of disruption going on in their life and other challenges week to week that might make it pretty difficult to successfully sustain that care, even if they can receive it. So in contrast, written exposure therapy, I think, has a lot of potential in this space because it's 5 sessions and there is no homework. All of the work is actually done in session. And the idea behind this is that it actually should not require specialized training. That it has been proposed that any clinician should be able to implement this. And I know that there's a lot of work going on looking at who can actually implement written exposure therapy. So one of the things we love about this might be much more palatable in community settings where this is going to require fewer resources to actually implement, and then patients might find that there are fewer resources as well. And if they're seeing benefits faster, even if they do have other things going on in their life, they may get an adequate dose of treatment before they drop out. So Jesse McCann, who I showed on the last slide, one of my graduate students, is focusing on adapting written exposure therapy for his dissertation for use with patients with PTSD who are receiving medication for opioid use disorder. So he is conducting a feasibility and acceptability study, as well as an initial test of efficacy using a multiple baseline single case experimental design. So it's a small N experiment that will allow him to establish some of these initial findings for support for this. So he's combining written exposure therapy with very brief harm reduction for substance use skills that have been adapted from the alcohol literature for harm reduction. And the idea here is that rather than being an abstinence-focused model, it's about a collaborative goal setting. So do patients want to seek abstinence for various substances that they might be using? If not, do they have a goal of cutting back? If not, do they have a goal of using in less harmful situations? So we might think about, for example, in the alcohol space, harm reduction might focus on, if you're drinking, can we set up a scenario where you'll be less likely to drive after you've been drinking? In the case of opioid use, so if we're thinking about harm reduction, Jesse is planning on providing all of the patients access to naloxone as well as fentanyl test strips to provide them some access to that care. And we're also providing referral information to all of the local needle exchanges. And all of these patients, importantly, are already going to be on medication for opioid use disorder. So we're hoping that they're already connected to a lot of these resources, but that's not necessarily a fair bet based on what we know and understand about access to care in Kentucky. So I'm really excited about this work and excited to see what comes out from it. So I'm going to switch topics a little bit here and talk, as I mentioned, about justice involved. In particular, the study that we're working on is focused on women. And justice involved women experience a whole host of unique issues and barriers to care. And unfortunately, Kentucky is a little bit of a race to the bottom state for a lot of things. The things that we're highest in tend to be things like, yes, we're ranking second in the nation for a number of currently incarcerated women. We are usually number 1 or 2 for rates of child abuse. It's not great. There's a lot of real challenges for us here in Kentucky, but it makes the work that I do, it's a great place to do it because there's a lot of need. So a former student of mine focused her dissertation on just trying to understand, similar to the KTOS study that I mentioned, trying to understand particularly in Appalachian, for Appalachian women who have been incarcerated in jail, what is the prevalence of violence? How much of a problem is PTSD? So that we can think about, is this something in the sample that we really need to think about? So she did her dissertation focused on something called the WISH study, which was an intervention to try to reduce hepatitis C and HIV infection among women who are currently incarcerated prior to being released from jail. Because another issue that we have are really high rates of hepatitis C and HIV infection in Kentucky. And as part of that, there was an assessment of violence experiences. And so we found in this study that 4 out of 5 women had a history of sexual, physical, or emotional abuse. And 70% of the women with abuse were above the clinical cutoff for current PTSD. So if you look at that in, I mentioned in the general population, current PTSD is about 1 to 3%, but it's much higher if you look at it in people who've experienced abuse. It ranges across studies, but usually around 20%. So even with that, 70%, right, it's dramatically higher. So we're definitely seeing this as a huge issue. This is Caitlin, who I mentioned, my former student, who is now a collaborator and is in the Department of Psychiatry here at UK. I've been very fortunate to have her come back and work as a colleague now. She is now leading another study with formerly incarcerated women that I am mentoring her through. And I'm really excited to share some of these data. It's really hot off the press. She let me borrow her slides for this. I'm going to give her full credit. But she just presented some of this work to our project team last week. So I'm excited to get to share it with you all. So this study is a mixed method pilot study that is focused on thinking about how can we engage some key stakeholders in both rural and urban areas. And importantly, we're looking at Appalachia and non-Appalachia in terms of that crossing with rurality as well. And so that we can explore the need for and thinking about barriers and also facilitators to accessing trauma-informed services. So this study focused on recruiting women who were on probation or parole and who had experienced, who had at any time in their life used heroin or fentanyl or misused prescription opioids. So they didn't have to currently be using opioids, but they needed to at some point in their life, because we were really focused on thinking about women who are at risk for opioid use disorder in this study. So this was my first time working in justice-involved populations. It's been a really interesting learning curve for both of us, in that in order to do this work, women on probation and parole, we have to work within the justice system and have them be on board with the research that we're doing. So it's been made for a really great opportunity to think about a community partnership with the system, to talk about and think about how can we understand how things are working in this system and potentially offer things to help improve this system without really focusing on the problems in the system. So I say that there in terms of like navigating the tricky political space of thinking about we want to support our folks in the justice system while also our partners in the justice system, while also highlighting areas that could be improved, right? So that's how I would think about it. So the great news about recruitment for this is that there's actually a text messaging system that can go to all of the women on probation and parole in the state of Kentucky. And it's broken up into different regions, which are then broken up into county, which allows us to really break this down and look at some of these differences. Although we have not yet, I will say, this is more of a snapshot. So of the 11,000 women on probation and parole that we reached out to in Kentucky, these numbers are outdated. The study is still ongoing, but about 750 initially responded with potential interest. We have some wonderful undergraduate RAs who are then matching all of those names to the Kentucky Offender Registry to ensure that those participants are actually eligible for the study. So that has resulted in almost 500 women who have been sent a survey link. So far, a little over 120 have completed our survey so far. and about 90 have been invited to participate in qualitative interviews. So our demographics here are overwhelmingly white and majority straight. We have about half who have completed high school or a GED. About half are employed. And it's important to note, there are some unique features of being on probation and parole and needing to maintain a job. So some of these numbers can be biased in some ways. The majority of participants identified as either being married or currently divorced or separated. And the majority also, the vast majority were parents or mothers. And almost half of the sample had some type of child protective services involvement. And over half had lost custody of their children. And this is of the entire sample. So if you look at that just among parents, it's actually quite a bit higher. So certainly this is a really relevant issue for women on probation and parole. In terms of justice involvement, what we're seeing is that about half of the women report that a drug possession was their last conviction, or drug possession with intent to distribute were the most common there. Only about 25% had something that was not drug related as their last conviction. The range of time on community supervision, so probation or parole, varied pretty dramatically for folks. And 31%, about a third, worked with a social service clinician. So if you're not familiar with the community supervision, probation, and parole system, which I was not, I'm learning a lot about it. Social service clinician, so people have their probation or their parole officer that they work with. And that probation or parole officer can choose to refer them to work with a social service clinician. And clinician in this way is a little bit of a misnomer because these folks are not clinically trained. They're often have a bachelor's degree or are a paraprofessional. And their role really is to engage with helping to connect these women with services out in the community. So they're kind of like a liaison. So only about a third are actually being connected there to think about referring them most commonly to substance use related care, but other mental health services as well. So let's talk about what we've found in terms of trauma and PTSD. And I will say that these numbers have been astounding. So we've looked at a variety of different types of trauma. And on average, we are finding that women have experienced 13 different traumatic event types. So that's not 13 different traumatic events. That's categories of events. So these women have been multiply traumatized. And if we look at sort of a general population, we usually find somewhere around 3 is like the average level of trauma types that people experience. So highly traumatized. And 80% report being afraid of a past romantic partner. They endorsed over 10 types of partner abuse, including emotional, physical, and sexual abuse. And we have specific categories broken up within that. And we're finding that a high number are also endorsing some form of past abuse in the last 12 months. So depending on what type we actually look at, it might range somewhere between 8 and 33%. And we're finding in the overall sample that, again, close to 75% are meeting criteria for possible current PTSD. So that's really a high number. So when we look at substance use in this sample, we're seeing that actually, at least in terms of what women are reporting to us, that there are very high levels of different, on the left-hand side here, if you look at that figure first, there are very high levels of lifetime use of tobacco, alcohol, various illicit drugs, as well as misuse of prescription medications, although current use, actually, their reporting is much lower, except for tobacco use. And these numbers, we have to recognize the sample that we're working with is that these women might not feel comfortable disclosing this information to us because they are currently being monitored on probation and parole. So this might be an underestimate. And then if we look on the right-hand side, this is a screening measure in terms of trying to identify people who are at higher risk for problems related to various substances in the past 3 months. So you can see, again, tobacco is really the most common issue here, which is really turns out Kentucky is also really at the top for tobacco use as well, and lung cancer. Okay, so in terms of treatment, we want to think about, are these women actually getting access to care? Because clearly they need it, and they are going to probably be experiencing a lot of barriers to that. So we found, it's great to see that this is during their lifetime. So we haven't had a chance to look in to see how much of this was during incarceration, how much of it's been after they've been released. So we don't know when they're receiving treatment, but a lot of women are actually at some point receiving some type of substance use treatment. Over half of women were not offered any kind of substance use related services while they were incarcerated. So there we do kind of have that piece. Most women reported that, at least now, post incarceration, almost 44%, a little bit less than half, reported that they were not getting the care, that they were already getting the care that they need out in the community in terms of what their needs are now with regards to substance use, or they don't feel like they actually currently do need help. So that's where we see that most of these women are, which was surprising to us. We actually thought that this would be an area of great need in terms of substance use services. When we go over to mental health, though, we see a slightly different picture. So we can see here the types of services in their lifetime that people have received. And so people have access care. But when we look specifically at evidence-based treatments for PTSD, only 8%, we described what these look like, and we gave the names of them, which we don't anticipate a lot of women might know that, but we described sort of what you do in an evidence-based treatment for PTSD, and only 8% of women said that they've ever been offered that, and only 6% have participated in it in the past. The other question we have is, are women being connected with victims-related services, domestic violence shelters, rape crisis centers, things of that nature? And when we look at this, despite our overwhelming levels of victimization, we see that the majority are not accessing those services. Now, we don't know if that's because they haven't been offered them or because they don't want them. What I will say is that we are also doing interviews with the social service clinicians who connect people with care. And one of the things that we've heard from a number of the social service clinicians is a lot of hesitancy to ask questions about violence, and they have talked specifically about not feeling like they know how to then connect people to care, or basically how to respond if someone says, yes, I am experiencing violence, or yes, I have previously experienced violence. And one thing that I think that is even more disturbing from what we've heard is we have state mandated education requirements for anyone who is in a domestic violence situation. So we are in the state of Kentucky required to provide education on how people can access a protective order if they need it. And we are to assist them with filing a report with law enforcement, but only if they want that to happen. And so actually, most of the service clinicians we talked to did not know that, which seems like clearly there's a space for some additional education and support of the clinicians that we're working with here. So I'm going to talk just a little bit about the impressions that we're getting from the interviews. Again, these are ongoing, but some initial impressions from the women themselves. So we're hearing a lot of acknowledgement for them, seeing connections between their own experiences of violence, mental health, and substance use. They feel like trauma is often addressed in their substance use treatment care, which is great. That's what we want to be seeing, but not so much in probation and parole. And so we're trying to think now, like, is going through probation and parole the best space, like actually thinking about justice involved care, thinking about it prior to or after incarceration, or thinking about more, can we connect people into the community better to help them get access to this care? Because women are reporting that they trust their substance use treatment providers more than they trust their probation and parole officers, the social service clinicians. So it makes a lot of sense, right? If you think about what the role is of folks in the justice system, is to ensure that they're complying with the terms of their community supervision. So there's a lot of concern about disclosing, and women talked about, being concerned about, actually, should I share or not? What I'll say is, the barriers here are many, but women are interested in thinking about care, but they have some barriers in terms of concerns about confidentiality, readiness, and timing. And I'm looking at my time here, so I'm going to just sort of skip over next steps. I'll say we're just thinking about where we need to go next, because I do want to make sure I have a little bit of time before I need to stop to talk about some of our work, a very different population after the significant flooding in Eastern Kentucky and Appalachian Kentucky in July of 2022, July of 2022. So we actually have an R01 that was centered in Eastern Kentucky, and actually in the town here featured on these images. Actually, the picture to the left was our local research office that was destroyed in the flooding. So we have a project that's actually focused on health disparities, sleep disparities in Appalachia, because we have found that the highest concentration of sleep disparities in the country actually is concentrated in Eastern Kentucky. And so while we were in the process of really setting this up and establishing our relationships with people in the community, this flood really devastated the area. So we have been in the process of doing a host of surveys and qualitative interviews with flood affected residents and leaders of community organizations, and also developing a community advisory board to think about what kinds of services and barriers to services in terms of recovery supports people perceive are happening there, and are there any innovative ways that we can deliver care to try to help overcome some of these barriers. So these data are also really, really fresh, because this is also an ongoing study. So I'll just really quickly share a little bit about this, and to say that we've done interviews with 25 residents, so small sample, qualitative interviews about 9 months after the flood. And we're in the process now, 6 months after that, of following people up to see how the recovery is going. We have a pretty good difference in terms of range of age and education, and also household income. So kind of going back to the piece of, there have been a lot of people have told us about stereotypes that people from Appalachia are all poor, and it's only the poor people who've been affected by this flooding. But in fact, that's not been true. And we've heard that from a lot of folks. And so we recruited from several different counties who were impacted by this flooding because it was very widespread. The largest actually problem that we're seeing people report clinically significant symptoms of is insomnia, which is really interesting. I don't know that we as psychologists are always thinking about sleep, except for it as a symptom of a lot of our mental health disorders, but we see huge overlaps and issues with sleep and PTSD in the area that I work, and then also, of course, with substance use. In Appalachia, an important thing to note, and in this sample in particular, we had relatively low levels of above the clinical cutoff for problems with alcohol and drug use. We do see in Appalachia stronger issues with drug use compared to the rest of the US, usually actually lower levels of alcohol use. And that's thought in part to do with cultural factors and strong religious factors in the area. But what we do find is that when people do have problems with alcohol, they actually are going to have alcohol use disorder at higher rates than the general population. So we have kind of some unique issues that we're addressing in Appalachia there. So going back to my social determinants of health piece, I think one of the biggest pieces that we're seeing is the economic impact. This is an area, so all counties in Eastern Appalachian Kentucky are in the bottom 10% of counties in the country in terms of economic opportunity and economic status. So this area overall is incredibly poor and has faced a lot of challenges over many years. And so we found, and when we look at just sort of basic needs, we found that before the flood, about 60% found it somewhat or very difficult to meet one or more basic needs, and on average 3. And then post the flood, we're looking at 92% are finding it somewhat difficult. And in our very preliminary work in this area, we have found that that difficulty meeting basic needs, the more basic needs that you have a hard time with meeting, that is associated with more severe depression, and it's associated with more severe, actually, I think I have it right here. Oh yeah, here we go. It's correlated with more severe PTSD symptoms, depression, and then actually post-traumatic growth positively. So it turns out that growth after trauma, which is not the same as resilience. Resilience you can think about as bouncing back from a trauma. Growth is having something new, positive in your life to come out of something like a disaster. And they are not always linked to difficulties. So sometimes people have a lot of symptoms, but they also have a lot of growth. And we are finding, in terms of alcohol-related problems, this is really relevant here. So we're finding, sorry, let me go back for 1 second. Difficulties meeting basic needs correlated with depression and somatic symptoms. Alcohol-related problems are positively correlated with PTSD symptoms, depression, and post-traumatic growth here. And although it wasn't significant with our very small sample, we're also finding that alcohol-related problems are related to these economic outcomes, which are often not the space of psychologists in thinking about how do we actually help people recover from trauma. So I'm not going to talk about my last study, but other than to say that we are now going to be scaling up our study on understanding recovery from the flooding in Kentucky as part of our ongoing longitudinal study looking at sleep health. We're going to be following people for 2 years over the course of a 5-wave study every 6 months. And it turns out that we were recruiting from 12 counties, and 4 of those 12 counties were impacted heavily by the flooding, and the rest weren't. So we're going to have some great opportunity to look a lot more into this.